Now we came to discuss other conditions affecting the periodontium. First, we will start with periodontal abscesses and endodontic lesions. Actually, periodontal abscesses represent approximately about 7 to 14% of all dental emergency, being ranked as the third most prevalent infection demanding emergency treatment after dentoalveolar abscess and pericoronitis. The periodontal abscess can be defined as acute or chronic lesions characterized by localized accumulation of pus within the gingival wall of the periodontal pocket or sulcus, rapid tissue destruction, and are associated with a risk of systemic dissemination. May be associated with fever, lymphadenopathy, and fatigue. Periodontal abscess may be found in periodontitis patient or in non-periodontitis patient. If it was found in periodontitis patient, the periodontal abscess could represent a period of a disease exacerbation favored by the existence of tortuous pockets, a presence of furcation involvement, or a vertical bony defect in which the marginal closure of a pocket could lead to an extension of infection into the surrounding periodontal tissue. Sometimes suppression of immunity or change in the oral microflora can lead to development of such abscess. A type of abscess in periodontitis patient could be a result of acute exacerbation as in untreated periodontitis or in refractory periodontitis or after a different treatment such as scaling, root planing, or a professional prophylaxis, surgical periodontal therapy, systemic antimicrobial intact without subgingival debridement, and use of other drugs such as nifedipine. In most of these conditions, there will be development of abscess due to closure of the orifice of the pocket, as an incomplete removal of calculus or deposit located inside the pocket, or change, as I said, in the flora due to antimicrobial intact. After closure of the pocket orifice, there will be a change in the nature of the subgingival microflora, leading to development of such abscess. Actually, the periodontal abscess must be well differentiated from periapical abscess, which may have the same sign and symptom. The tooth is vital in case of periodontal abscess, while it is non-vital in case of periodontal abscess. The lesion in periodontal abscess located lateral to the root surface, while it is located mostly periapical in case of periapical abscess. X-ray finding regarding the periodontal abscess show the area of radiolucency along the lateral surface of the root, while it is apical radiolucency in case of periapical abscess. Finally, the tooth is tender to lateral percussion in case of periodontal abscess, while tender to vertical percussion in case of periapical abscess. Now we are going to discuss endodontic periodontal lesion, which are clinical conditions involving both the pulp and periodontal tissue and may occur in acute or chronic forms. Actually, two types of endo lesion we have. First, endoperiodontal lesion associated with endodontic and periodontal infection. They might be triggered first by a carious lesion that affect the pulp and secondarily affect the periodontium. That is mean it is a primary endo and secondary perio lesion. Second, by periodontal destruction that may secondarily affect the root canal either through lateral canals or periapical canal. That is mean the condition is a primary perio and secondary endo lesion. Or 3, we have development of both events concomitantly. As in a true combined lesion, there will be a development at the same time of a perio lesion and endo lesion. So we have a perio-endo lesions. The second type of endo-perio lesion associated with the trauma and iatrogenic factors. These conditions usually have a poor prognosis as they affect the tooth structure, and the most common lesion in this category were root and pulp chamber forcation involvement because of root canal instrumentation or tooth preparation for post-retained restoration. Second, root fracture or cracking because of trauma or tooth preparation for post-retained restoration. Third, we have external root resorption because of trauma. And finally, due to pulp necrosis because of trauma and draining through the periodontium. After the discussion of periodontal abscess and endo-perio lesion, we came to the mucogingival deformity and conditions around the tooth, and these include the mucogingival deformity and condition around teeth that include the periodontal biotype, thin scalloped, thick scalloped, and thick flap, and in addition to other conditions involved in this category. The meaning of mucogingival is a term used to describe that portion of the oral mucosa that cover the alveolar process, including the gingiva, keratinized tissue, and the adjacent alveolar mucosa. And I will start my discussion with a gingival biotype or periodontal biotype, which include in its definition the gingival thickness and keratinized tissue width. It can be divided into a thin scalloped biotype in which there is a greater association with cylinder triangular crown, subtle cervical convexity, interproximal contact close to the incisal edge, and narrow zone of keratinized tissue, a clear, thin, delicate gingiva, and we can see the probe transparent through the gingival tissue after the insertion in the sulcus, and relatively thin alveolar bone, as in a picture. The second, we have a thick, flat biotype showing a more square-shaped tooth, crowns, and a pronounced cervical convexity, large interproximal contact area located more apically, a broad zone of keratinized tissue associated with thick fibrotic gingiva, and comparatively a thick alveolar bone. And we can see this in picture B, and the probe was non-transparent through the gingival tissue. In addition to the gingival or periodontal biotype, we also have a gingival recession as a part of a mucogingival deformity and condition around the teeth. Is a location of gingival margin apical to the cemento-enamel junction. The cause of gingival recession may be due to plaque accumulation that will cause a destruction of the junctional epithelia as a result of an inflammatory process, or due to traumatic gingival recession such as a faulty toothbrushing technique, tooth malposition, high frenal attachment, overhang filling, a prosthetic appliance, and habit such as nail bitings. As a part of other condition and deformity affecting the periodontium, we are going to discuss the prosthetic and tooth-related factor. These are factors may modify or predispose to plaque accumulation or biofilm accumulation and lead to the induction of gingival disease and even periodontitis. We have either a localized tooth-related factor or localized dental prosthesis-related factors. The localized tooth-related factor that modify or predispose to periodontal disease, including a tooth anatomic factor such as enamel tear, cemental tear, cervical root resorption, root fracture, root proximity, altered passive eruption, and also developmental groove and anomalies on the tooth and root surfaces. The prosthetic related factor included in a tooth prosthetic related factor involve restoration margin that are placed within a supracrystal attachment tissue, such as a subgingival finishing line that will lead to a violation of biologic width or supracrystal attachment tissue. Second, the clinical procedures that related to a fabrication of indirect restorations. Actually, several conditions exist in a teeth or prosthetic design may predispose the periodontium to develop a disease. In certain cases, these factors may contribute to the initiation of periodontal disease. We all know that the etiology of periodontal disease is bacterial and foundation of a biofilm dental plaque. The factors that enhance this biofilm formation and accumulation or allow ingress of bacteria into periodontium should be considered in the classification of periodontal disease and in the initiation and development of gingivitis or even periodontitis. Now we discuss the traumatic occlusal forces that may lead to the development or progression of periodontal disease. We have three types of occlusal forces: the primary occlusal trauma, secondary occlusal trauma, and finally we have orthodontic force. Actually, occlusal trauma can be defined as injury resulting in tissue changes within the attachment apparatus, including periodontal ligament, alveolar bone, as a result of excessive occlusal force. And as we said, we have a primary occlusal trauma, secondary occlusal trauma, and orthodontic force. Normally, the tooth that can tolerate a normal forces directed vertically with the long axis of the tooth, as you see in the white arrow, while the trauma that is subjected to the tooth surface laterally, such as in the red arrow, will lead to primary occlusal trauma, which is injury resulting in tissue change from traumatic occlusal forces applied to the tooth or teeth with a normal support. That is mean there is a normal level of alveolar bone, normal attachment level, and excessive occlusal force, while the secondary occlusal trauma is injury resulting in tissue changes from normal or a traumatic occlusal forces applied to the tooth or teeth with reduced support. That is mean it occurs in the presence of bone loss, attachment loss, and normal or excessive occlusal forces applied to the tooth surfaces.